people have probably seen a slide similar to this. This is from our colleagues at CMS, showing their goals of moving us from a historical state of producer-centered, volume-driven, unsustainable, fragmented care to a future state of people-centered, outcomes-driven, sustainable, coordinated care with the help of new payment systems and other policies, such as the Hospital Readmission Reduction Program. So this is a slide that was prepared under the previous administration, showing that about 85% of fee-for-service payment from CMS is now linked to quality. They did hit and sustain that target, but of course in the current administration they backed off a little bit from some of the alternative payment models, some of the bundled payment models that you've been hearing about. So I don't think they're going to hit the 50% target, but nonetheless there's been a continuing increase towards more of these alternative payment models. So the ACA contains these three hospital payment innovations, and of course we're all familiar with these from our work on the ground. We'll be talking today about the Readmission Reduction Program. So as you know, this program reduces base DRG payment amounts in hospitals that are determined to have excess readmissions based on a risk adjustment model by a factor which is limited to 3%. And this factor comes out of the ratio that's shown near the bottom there, where they add up the aggregate payments for excess readmissions according to the risk adjustment model across the 6 conditions, and they divide that by the aggregate payment for all discharges to come up with this penalty amount. So there are a variety of peculiar features of this penalty scheme, which you can observe right off the bat. But one is that if your hospital is more heavily invested in care for these conditions, if a higher proportion of your patients have these target conditions of heart attack, heart failure, pneumonia, total hip, total knees, COPD, and CABG, then you're more likely to get a penalty. Similarly, if you get a penalty because this calculation is done separately for each of the conditions, you can have an overall readmission rate that in fact looks great and meets the goals that we discussed, but you can still get a penalty because in one of those 6 conditions you may have excess readmissions according to the risk adjustment model. So many of us are a little bit skeptical about this, think that one of the primary reasons why this policy was built into the ACA was because the CBO scored it with a 10-year savings of $7 billion. It was part of the package of pay-fors, if you will, that were necessary in order to show that the program was neutral in terms of its impact on the federal budget. But anyway, this is a quick review. I think you're all familiar with the target conditions, AMI, COPD, heart failure, pneumonia, total hips, total knees, and CABG across the top, the historical pattern of development. So first of all, I'm going to ask a little bit about what's the impact been at the national level. Is it working at the national level? And then we'll talk about the 7 main issues. So overall, if you look at the current fiscal year, 2018, about a little under 80% of hospitals are penalized. So I think probably all of our hospitals had some penalty. I'll show that in a minute. The average penalty was 0.73%, so if you're less than that, you're doing better than average. The total clawback to CMS is estimated at $564 million. So that sounds like a lot of money. It is a lot of money. But of course, others may say, well, it's really much less than the $41 billion that was spent on readmissions within 30 days in 2011, and that's the present. And it's even less than the $4 billion or so that's spent on readmissions for these target conditions in 2011. So that clawback is significant, but in the bigger scheme of things, people view it as modest. Now this may be hard to read, but it just shows as the program has developed, the average hospital penalty has increased. So we started out with average hospital penalties of around 0.3, 0.4%, and the last 2 years we've been up around 0.74, 0.73%. get about 80% of hospitals penalized. So very similar between fiscal 2017 and fiscal 2018 in terms of the national impact. What we have seen, though, as well, is that the penalties have hit certain types of hospitals disproportionately, right? So you can see, in particular, the hospitals that are in the top quartile in terms of their proportion of patients who are low income. Those hospitals have had a higher average penalty, 0.69% versus 0.47%. And a somewhat higher percentage of those hospitals have been penalized. So overall, the penalties have hit a bit harder on safety net hospitals, on hospitals that have disproportionate share for low-income patients. But again, the great majority of hospitals in all settings, in all geographies, have suffered some penalties. Yeah.
I'm so sorry, but that's so small. Could you maybe elaborate, because I don't think anybody can read that.
Sure, I'm sorry. And we'll make sure the slides are posted afterwards. So the middle column here is the column that shows the average hospital penalty, and the column to the right shows the percentage of hospitals with any penalty. So basically, and this is the hospital stratified by various characteristics. So teaching hospitals have a little bit higher penalty, 0.66%, versus non-teaching hospitals at 0.57%, I think, 0.58. But it's really a very small difference between teaching hospitals and non-teaching hospitals. So the largest difference across the hospital strata is according to whether hospitals care for a higher proportion of low-income patients. So, sorry about that. Okay, so this is a little bit more readable. This is us. So this is how the readmission penalties have hit us here in the Sacramento area. So you can find your hospital up there, and I highlighted in red, all the penalties. So you can see that in the last 2 years, all of us have suffered to some degree of penalty, and the penalties have been generally pretty stable between 2017 and 2018. Some have decreased a bit, some have increased a bit, but this is a problem that we all share. So now, is the program working? Is the program doing what it's supposed to do at the national level? And I think, as you've heard in this area and other areas around the country, readmissions have decreased. So over the period before the implementation of the program, in fact, readmission rates were quite stable for several years. And then suddenly, lo and behold, after or during the period of program implementation, readmission rates took a significant drop, as you can see here. But they've been stable nationally for about the last 2 years. Okay, so it seemed like there was some excess readmissions that we were collectively able to squeeze out, but then we've had a little more trouble, perhaps as we get into a more difficult situation, we've taken care of the low-hanging fruit. But now the readmission rates have stabilized nationally. So here's another presentation of the same data, a little bit more elegant, from the New England Journal last year from Arnie Epstein's group, showing that if you compare the targeted conditions with the non-targeted conditions, readmissions dropped more for the targeted conditions than they did for the non-targeted conditions. Okay? And that's what we expect, because we've all, in our hospitals, we've all focused particular effort on heart attack, pneumonia, heart failure, total hips, total knees, these patients. But we also anticipate that there's been some spillover effect, right, on other kinds of admissions, because the systems that we're putting in place to reduce readmissions are expected to have some effect on patients with other conditions and procedures as well. So this is exactly what we might expect, that there's a spillover effect on non-targeted conditions, but still the magnitude of the effect is greater for the targeted conditions. But again, notice that the slope is zeroed out for the last 2 years, going through 2016 as well. Here's another way of looking at it from the same analysis. looking at the question of whether we're just shifting all of these readmissions to observation stays. So maybe we haven't actually gained anything because the same patients who were previously readmitted are now being kept in overnight for observation stays. And lo and behold, there has been an increase in observation stays, but that increase has been consistent throughout this period, not showing the same kind of step pattern that we saw for readmissions. And it's only very slightly more for targeted conditions than for non-targeted conditions. So yes, there's been an increase in observation stays, but the slope of the increase is less than the decrease that we saw for readmissions, and it doesn't compensate for the decrease that we saw in readmissions. Another way of looking at this question of impact, as the folks at Yale did, Susanna Bernheim's and Herman Krumholz's group, they compared the trends over time in the hospitals that are subject to the penalty versus the hospitals that are not, the critical access hospitals and other hospitals that are exempt from the fee-for-service penalty scheme. So you can see in blue the penalized hospitals and in orange the non-penalized hospitals. And in each case, you can see that there's been some narrowing. So the penalized hospitals continue to have higher readmission rates. That's not surprising because they have sicker patients in critical access hospitals. But you can see that the gap has narrowed a bit over time. So again, as experts might expect, the penalty scheme appears to have had a greater effect on the hospitals that are subject to it than the hospitals that aren't subject to it. We've responded, essentially, as you might anticipate, to economic incentives by reducing our readmissions more than the hospitals that are exempt. Okay, so it seems like there's been some impact at the national level. But we and others, have been sort of trying to rethink this because this obsessive focus on 30-day readmissions seems a little bit limiting. And we wonder about, how much of this is actually due to what the hospital does, how much is due to the outpatient, the whole system of care, including pharmacies, home nursing care, skilled nursing care, etc. So this was, so I was asked to present a little bit from this paper. This was a paper that we published in Health Affairs last year. And so we were sort of revisited the question about why 30 days? It's a rotation of the moon around the Earth. What does that mean? So the rationale for 30 days was, as stated in the CMS reports, that readmissions in this period can be influenced by hospital care and early transition to the outpatient setting. And it seemed like a clinically meaningful period for hospitals to collaborate with their communities to reduce readmissions. But the empirical evidence to support this particular interval is actually quite slim. So our hypothesis was that the 30-day interval is really too long to measure the hospital attributable quality signal. And that if we're really trying to sort of parse out attribution or blame, if you will, then other players would have to get involved as we go further out from the hospital discharge. And there's some preliminary evidence to support that hypothesis in more detailed studies looking at a detailed review of medical records. Graham's group out of Harvard showed that early readmissions within 7 days were associated with markers of acute illness burden, including things like whether or not the response team was called during the hospitalization, markers of chronic illness burden, and barriers to learning. Early readmissions were less likely if the patient was discharged in the morning. We've all been working on that, right? Late readmissions were more strongly associated with markers of chronic illness. You can see those odds ratios are higher than the odds ratios for early readmission, and more strongly associated with social determinants of health, including particularly barriers to learning and having unsupplemented Medicare or Medicaid. Okay, so there's some preliminary evidence that the late readmissions have more to do with social determinants and more to do with chronic disease, and the early readmissions may have more to do with the acute illness situation. So we collected data through the HCOP program, which is the program managed by AHRQ, collecting state and patient data like Auschwitz data. We collected 66 million records from three of the largest states, California, Florida, and New York, and one smaller state that had very good data, Arizona. And we basically re-implemented CMS's analysis using the same risk adjustment models and methods that they use for a variety of conditions. And this basically just summarizes about 90% of those patients who were in the sample were Medicare, about 10% had other types of insurance listed as primary. We tried the analysis with it without them, it didn't make a difference. So this happens to include them. Now, I won't get into the math here, but this is the CMS model. The point of this model is that there are certain hospital-specific intercepts. Those are the terms that represent each of our performances relative to the national average. There are patient-specific covariates. Those are all the things that we adjust for, those clinical risk factors. And there's a between hospital variance, and there's an error term. So we're focusing now on this error term, which represents the variance, the unexplained variance in this model. Okay, so it turns out that there is a mathematical relationship called the interclass correlation coefficient. I won't bore you with the details, but basically what this does is to create a ratio to look at the proportion of the variance between hospitals over the sum of the between hospital and the within hospital variance. So what does this mean? So within each of our hospitals, we've got some sick patients, we've got some healthy patients, right? And so there's a lot of variation in risk within our hospitals. But there's also some variation between hospitals, okay? So if some of us are doing better than others, then that's a between hospital effect. And that between hospital variance represents the portion of the variance that is attributable empirically to what hospitals are doing. Okay? So this graph actually shows what that proportion is. And you can see that these percentages, the y-axis here is in percent. Okay, so we're talking about 1, 2, 3, 4%, okay, of the total variation. Okay? Now, it may not be surprising that most of that variation is due to patient characteristics, okay? And that's accounted for in the risk adjustment. So how much is due to hospital signal, if you will? So in the first day or two, you can see it's quite high, perhaps 2-3%, and then it drops. This shows what happens over time. And you can see that as we start getting out towards a week and more, we're under 1% of the total variation that's due to, attributable to hospital differences between hospitals. This shows over the whole period of 90 days what happens. And what you can see, this is kind of interesting, is that this between hospital variation drops fairly dramatically, and then it stays low, and then it actually starts to increase. It actually starts to increase as we get out towards 30 days and beyond. Okay? So what is that telling us? So this is the early time when there's relatively high between hospital variation. This is the time around 30-60 days when there's relatively low, and then coming out further out towards 90 days, it seems to increase. So we noticed, of course, that no matter what hospital you're in, that the patients who have a lower median income, or specifically live in zip codes with lower median income, have higher readmission rates. That's the top line. So we were interested in doing some additional adjustment for these kinds of demographic factors. And that's the math for it. And basically what this shows is that when you adjust for these additional sociodemographic factors, the hospital signal drops even further, drops to about 0.5% or 0.6%. And the curve is pretty much flat. Okay? So what this is telling us is that most of these later readmissions are really heavily related to the sociodemographic characteristics of the patients. Now, that doesn't mean that we're powerless to do anything about the problem. Okay? What it means is that we have to be sensitive to the fact that there are particular patient risk factors that put the patients at higher risk during this later period. And okay. So again, early readmissions in the first few days are particularly under the hospital's control, and later readmissions appear to have a mixed etiology. So some limitations. Obviously, this kind of mathematics that I've shown you is not intuitive. I've done my best to explain it to you quickly, but we can talk more about it. The states may not be represented, but of course we're in California, so that's good for us. And we may have underestimated some of the patient risk factors, because of course there are clinical risk factors that aren't included in the CMS models. So in conclusion, between hospital readmission variation turns out to be really very small after 7 days. Non-hospital risk factors contribute more to readmission risk as we get out to past 7 days. And therefore, further reduction in readmissions after the low-hanging fruit that we've taken care of in the last couple of years, not to be pessimistic, but it's likely to require really exceptional integration and continuity between inpatient and outpatient care. And this is sort of a theoretical extrapolation of what I've shown you, that as the red portion, as the hospital, as the part that's related to hospital inpatient care decreases over time, the part that's due to comorbid conditions in green is empirically estimated, that's substantial, and it continues over time. But there's an increasing portion that's related to the environment, and of course our ambulatory care is very much a part of that environment. And this is a graphic representation of how complicated it is, but all of us know that. So I'll stop there and just open it up for discussion.
I have a question for you, Dr. Romano. Are you concerned that based on what you just presented, that hospitals will avoid patients from those zip codes that are more likely to result in higher readmission and therefore a penalty?
Is anyone doing that? I mean, yes, it's a hypothetical concern. I mean, the fact is that, especially for these patients, with the exception of the total extremities and cabbages, we don't have a lot of control, right? Because these patients are mostly coming to us through the emergency department, and they're being brought in by ambulance for the most part. So at least you might be more sanguine about that. But as far as the elective surgeries, yes, I think that there is some concern about whether not just this program, but other programs, you know, the hospice program on cabbage reporting and other programs, create an environment in which there's some incentive to sort of cherry pick patients from better zip codes, patients in better socioeconomic, better social networks, so forth.
So, Dr. Romano, so would you say that in looking at the data, hospitals are looking at their own data on an ongoing basis. The 7-day readmission?
The 7-day readmission, where we, in our data for Medicare fee-for-service, we're showing like 39% are coming back within 7 days. Would you say that those patients, the reasons for them to come back is most likely related to something that the hospitals can do and within their influence and their quality performance, so to speak, is related more closely related to that?
Yeah, I think that there's pretty good evidence about that from a couple sources. Again, it's not necessarily over 50%, but there's some older literature from Carol Ashton and Melba Ray and colleagues showing that patients who had abnormal vital signs at discharge were significantly more likely to be readmitted within 7 days. Something very simple, you know, we've all been there. I mean, there's pressure, everything's set up, you want to discharge the patient. But what do you make of the fact that the heart rate's 110? So it turns out that patients who are discharged with abnormal vital signs are more likely to be readmitted within 7 days. Also, more recent work from the Harvard group, from the Graham's group, showed that patients who had abnormal mental status exam within 24 hours of discharge, 12% of them were readmitted. So it was again a very significant risk factor for readmission within 7 days.
Could you say what that is again?
Abnormal mental status exam, so signs of delirium within 24 hours before discharge. So, obviously these are patients who are acutely ill. Post-operative delirium, ICU delirium is not uncommon, but we'd like to see that resolved. There's a lot of, obviously, pressure to get patients out quickly, but that's been shown now to be a risk factor. So there's some interesting work that's only been presented in abstract form from a consortium of teaching hospitals around the country, including UCSF, also showing that when physicians look at the records of the patients who had an early readmission, they're much more likely to find something that was potentially preventable during that hospital stay or in that discharge process.
You're referring to Dr. Auerbach's?
Yes, exactly. Right. Is he presented here?
No, he presented at our LA conference last month, a couple of months ago.
What we're talking about is a study that was published by Dr. Auerbach from UCSF. And if you don't know about it, just email us and we'll give you that reference. Any questions from the audience?
Dr. Bowman?
Pat, I have a question. With the small variation between hospitals, that risk adjusted for their social economic gets smaller and smaller, is our current 3% penalty for readmissions, which has been toned down to 0.7%, as you said, roughly nationally, is that the best incentive to try to reduce readmissions?
Right. Well, that's the 30,000-foot question.
Yeah.
And I think my response to that, and the response of other people, would be that policymakers chose to focus on hospitals first, but I think it's become clear that the burden needs to be shared, and that especially as we try to move into more integrated models of care, that we need to figure out ways to sort of reapportion that penalty. There's obviously some analytic work underway to develop a penalty scheme for nursing facilities, for skilled nursing facilities, and possibly for home health agencies. That's just subject of, I think, still some consideration. So I think your point is well taken, that we may have gotten about as much as we're going to get out of this particular hammer, and it may be time to find some other hammers, or to find some carrots.
Could you possibly talk about carrots related to outpatient intensive care at our new scheme work?
You may know more about that than I do.
So, how about, could you say something about whether you see a variation between managed care patients and fee-for-service patients in readmissions?
It's an interesting question, and we, obviously you can see that